Hello, everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm really honored to welcome you to this week's webinar that's titled Breast Cancer Therapy 101. Before we begin the webinar, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle classes, social activities, and educational programs like this one. And if you want to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce today's speaker, note that your video and microphone are automatically disabled for this webinar, but we really encourage you to enter questions for the speaker into that Q&A feature found at the bottom of your Zoom window. And questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we will be recording the webinar, and you'll be able to have that for reference. And the chat feature is open as well, and please use that to share comments or resources that are relevant to this topic. But please enter those questions into that Q&A feature so we can keep all of those together. So I will introduce Dr. Peddi. Dr. Parvin Peddi is the director of the Breast Medical Oncology Unit at Margie Petersen Breast Cancer Center. After nearly a decade at UCLA, where she was a member of the Medical Oncology faculty and lead medical oncology at the Revlon UCLA Breast Cancer Clinic at Ronald Reagan UCLA Medical Center, Dr. Peddi joined the Margie Petersen Breast Center at Providence St. John's Health Center. She specializes in the treatment of patients with breast cancer and is involved in designing, implementing, and leading clinical trials to test new targeted therapies. She is board certified in internal medicine and medical oncology. And it gives me the greatest pleasure to welcome today's speaker, Dr. Parvin Peddi. Welcome.
Thank you so much, Kathy.
Yeah.
And yeah, privileged to be here. And I echo what you said about Cancer Support Community. We are very, very lucky that we have this service in our community. And anyone, participants who have not taken advantage of Cancer Support Community, please do so. Like Kathy said, everything is free of charge and is run on philanthropy only, and is a great community resource in all sorts of ways, educational, yoga, like anything really. And if you just, look, you will probably find something that would perhaps be helpful to you. Yeah.
Thank you, Dr. Peddi. Appreciate that. I'll see you at the end. We'll have one closing slide to share.
Perfect.
All right. Thank you. Welcome.
I will share now my screen. Okay. So this talk is meant to be an overview of breast cancer. Now, some of the people who are joining us today may have had breast cancer themselves, may have had it in the past, may be dealing with it now, or may have a loved one who has breast cancer. So hopefully it gives an overview of the different types of breast cancers, different types of treatments, bird's eye view, and then we'll have plenty of time, hopefully, for questions, so we can get into any areas that are more important to you. So When someone comes and is diagnosed with breast cancer, the mammogram could look like this. I'll start at the basics and how it's diagnosed. So, this person's breast is what we call a fatty breast, meaning we can see things clearly. There are not too many glands. Someone who is described as having a dense breast, there's more white background overall and harder to see things because, as you see, this person has a mass in the middle, and that also comes out as white. And if there's a lot of glands also, then it's hard to tell the mass apart. And so when a mammogram picks up something, then the next step would be ultrasound as well to confirm it, because you need a biopsy of this thing, and it's easier to do a biopsy with ultrasound rather than mammogram guidance. So this could be what a breast mass looks like under ultrasound, like oval, but not in a nice circle, round way. And a lot of times at diagnosis, we also get an MRI. Not everybody needs an MRI. An MRI can give false positives. But if there, again, is dense breast, so you can't really see things clearly on mammogram, or if that person is very young, which usually goes with dense breast, for surgical planning, for lobular type of cancer, which I get to later, those would be reasons to do a breast MRI. And here's an example of what a very obvious breast MRI with cancer looks like. Not all are this obvious, but this person happens to have this mass in the right breast, basically. So now, when we find breast cancer in someone, doesn't everybody need genetics, or why did that person get it? This is a question I get asked a lot, especially when people first come in and are just diagnosed with breast cancer, because we always want a cause. We always want to know, why did this happen? Unfortunately, a lot of times we don't know. Very few of people with breast cancer got it because of genes. Only about 5 to 10% of breast cancers are hereditary. Most common genes that you may have heard of are the BRCA1 and 2, PALB2, and there are other genes as well. Because it's not common, not everybody needs to have genetic testing done. We typically do it on people who are younger, diagnosed younger than age 50, people who have two different breast cancers, maybe on both breasts, male breast cancer for sure, people who have a first degree relative, so that's a sister, a mom, with breast or ovarian cancer, who was also diagnosed young, especially Ashkenazi Jewish descent, because a lot of those patients carry BRCA, and anyone with metastatic breast cancer, not because it's more common with people with metastatic breast cancer to have genetic disease, mutation, but because there is one particular medication that is approved for people with metastatic breast cancer who have a BRCA1, 2, or PALB2 mutation. So because it can give us an additional therapeutic option, everybody with metastatic breast cancer should get a genetic test too. But still, most of them don't have a gene that you find. Breast cancer staging. So stage 1, 2, 3 is considered localized. So any breast cancer that is confined to the breast and or lymph nodes falls into one of these categories. And the goal for patients with this stage of breast cancer is cure. Stage 4 breast cancer is when it's spread to any organ outside of the breast and lymph nodes. So could be bone, liver, lung, brain, really any of those organs could happen. And stage 4 breast cancer, unfortunately, right now, it's not curable, but it is manageable. And a lot of these patients, we are able to put them in some kind of remission for many years, a lot of times, and hoping for better and better things to come along as they go through their therapies. So now the types of breast cancer. So the main types based on the cell type are ductal versus lobular types of breast cancer. So when someone gets a diagnosis of breast cancer, there's like a big long name, and you may say invasive ductal carcinoma. So carcinoma just means cancer. Invasive means it broke through the wall of wherever it started out from. And ductal versus lobular are the cells that it started out from. So milk is made in the lobules, goes through the ducts to get through the nipple. So breast cancer can start in the lobules or in the ducts. Now, does it matter if someone has a ductal cancer versus a lobular cancer? The only thing it really matters in is that lobular cancers can be more infiltrative and not as much mass-like, and they can be underestimated or missed on mammogram. So for lobular cancers, we almost always like to have a breast MRI as well, because you can see the extent of them better for surgical planning. But once you've done the surgery, once you know the stage, it doesn't really matter if it was ductal or lobular. The treatment is the same, and the treatment is more dependent on the type of receptors that the breast cancer has. So, as part of the pathology report, also, when a person gets a diagnosis of breast cancer, automatically they will get the receptor status of the breast cancer, because we're trying to understand what does it rely on for growing, because not every breast cancer is the same. And that matters in terms of how aggressive it is, what do you treat it with, do you do chemo, do you not, what type of chemo. So all of that, at least the first basic thing is, does it like estrogen or not? So that's the first receptor status that is listed, estrogen and progesterone. And they usually go hand in hand. But if they don't, estrogen is the more important of the two. And if they are positive, then we can use anti-hormonal medication for that patient. And then the third receptor that also gets reported in automatically in everyone's breast cancer pathology report is this thing called HER2, HER2. So what is that thing? So it's a protein that on the left is a normal cell, normal breast cell. And this protein, the HER2 gene is inside the nucleus and is expressed on the surface. This HER2 molecule. So it is there even in normal cells, breast and otherwise. But in HER2 positive cells, which the correct terminology really is HER2 amplified, but for simplification, we say HER2 positive, we have tons more of this receptor on the surface. And this receptor is a growth signal. So when it gets activated, two of them dimerize and then cause a signal cascade that causes the breast cancer cells to grow faster and be much more aggressive. So the so-called HER2 positive cells, cancers are about 20% of breast cancers. So 1 out of every 5 women who is diagnosed with breast cancer has a HER2 positive breast cancer. Again, what does it matter? Because number one, it tells us that it's much more aggressive. It's much more likely, even when it's small, to get out of breast compared to non-HER2 positive breast cancers. Number one. Number two, we have really good drugs against it. So we have specific anti-HER2 drugs that if these patients get treated with them, they actually do better than other types of breast cancer. So not only is it worse if you don't know what it is better if you know what it is. So that is also very crucial to know. So the goals of therapy, as I mentioned, 1 to 3, stage 1 to 3, the goal is cure. But higher percentage of stage 1 patients are cured versus grade 3, but still majority can be cured. And in a metastatic disease, remission, prolongation of life, and improving symptoms. So I'll now briefly talk about the different types of treatments depending on the receptor status of a patient's breast cancer. So first, the most common, hormone receptor positive breast cancer. So that's roughly about 70% of breast cancers are hormone positive. And if found out about in a localized setting, meaning stage 1, 2, 3, usually the treatment is just go for surgery at the beginning. If it can be taken out, if it's not too big, upfront surgery, and then a lot of times followed with radiation therapy. But treatment is not done with surgery alone, even when a cancer is small, because there is a chance that a few cells escaped and are out there somewhere else. And if those patients don't take something that goes throughout their body, this cancer can come back years down the line and unfortunately be stage 4 at that point. So we want to give everybody some kind of systemic therapy afterwards if they can tolerate it. Now, what is the systemic therapy, so-called, meaning something that goes throughout the body? And so I'll get to that. And then more important thing is, even if the lymph node is negative, doesn't mean the cancer could not have spread, because that 1 or 2 lymph node is just a potential gateway, but is not the only gateway for the cancer to get out. It could go through other lymph nodes, it can go through the bloodstream, it could go through that particular lymph node that you sampled, but it didn't make a home there. It went right on through, so you didn't catch it when it was there. So negative lymph node doesn't mean surgery cured the patient 100% and nothing else is needed. So we send this test called Oncotype. You may have heard of it. Some of you may have had this test done. This test is to try to figure out if these patients need chemotherapy in addition to the anti-hormonal therapy. And what it is trying to understand the cancer beyond, oh, it's just estrogen positive. Because some of them are aggressive and just treating with anti-hormonal is not enough. But some of the other ones are very slow growing and anti-hormonal is plenty and they do not benefit from chemo even one bit. So this Oncotype DX is a genetic profiling of the cancer. So we send a little piece of the tumor tissue to this company that does it nationally for everyone in the US. And 16 particular genes are analyzed. And these are genes that are important. These are genes that are either important in the cancer being able to divide quickly or the cancer being able to get out of the breast better. So then it gives you a score, and that score is so-called recurrence score. And the lower that score is, the less likely it is that that patient would need chemo or benefit at all. So the scenarios we send this is a postmenopausal woman who has no lymph node involvement found at time of surgery, or just 1 to 3 lymph nodes positive. And any score less than 25 reliably predicts that that person does not need chemotherapy. It's a little bit more tricky for premenopausal women. If they were, before that, let me just briefly say, for premenopausal women, if they didn't have a lymph node involvement and is less than 18, there's a recurrence score, they don't need chemo. Between 18 and 25 requires a discussion because there may be some benefit. If they have positive lymph nodes, there probably is benefit from chemo in premenopausal women, even if it's just one lymph node. But it does require discussion with your oncologist because it's not set in stone and it does have some nuances. And then whether you do chemo or not, everybody with a hormone receptor positive breast cancer needs to get an anti-hormonal medication. Now that can be tamoxifen, that can be a class of drugs called aromatase inhibitors. And the choice of that, again, depends on the person, their age, their bone density, a lot of different factors, but they're all possible. And sometimes we add a drug to that, to the anti-hormonal therapy. So there's a new class of drugs approved, CDK4/6 inhibitors. So CDK4 and 6 are proteins that are gatekeepers for the cells to divide. And if we inhibit that, the cells kind of get stuck, these cancer cells, in the step before the actual division. So they try to divide, but then they just can't do the last step. And if you combine these with anti-estrogen therapy, like they're stuck in the step before and they can't get the food, which is estrogen, and they gradually die off. So the 2 drugs in this class currently approved, Verzenio and Kisqali, but there's specific criteria. Not everybody benefits. The cancer has to be a little bit higher risk for you to see a benefit from these because they do have side effects and they need to be taken for 2 or 3 years. But is an option and can improve cure rate, especially for stage 2 and 3 patients, whether they got chemo or not. And a lot of times we also add something for their bones. Number one reason is that the anti-estrogen medicines can make the bones thinner and cause osteoporosis potentially. But also, especially for higher risk patients, these bone medicines, Zometa is an example of it, can potentially prevent breast cancer going to the bone, some kind of a protective shield for the bones as well against the cancer. So there are more options than just anti-hormonal therapy, but everybody is going to be treated different based on their risk, based on their tumor biology. Okay, now HER2 positive breast cancer. Again, bird's eye view. There's a lot more to discuss that I can discuss in this 1 hour. But as we talked about, HER2 positive, 20% of breast cancers, and I told you it's more aggressive, you need to treat it right. So what does that mean? So a lot of times it's actually chemo before surgery. So why is that? Number one, chemo works really, really well. So even if the cancer is big, you give chemo, you may have little or none at all at the time of surgery for HER2 positive breast cancer patients. And number two, probably a more important reason, is that this is a field that we have a lot of options in. So we can give people a lot of chemo, we can give them less chemo, we can give them something in the middle. And if you treat them before surgery and you picked whatever you picked, then you can watch the tumor and see what it does. Is the cancer getting smaller by the time you go for surgery? Is nothing left? Then you picked the right thing. And great, you don't need to give them more afterwards. Or you picked kind of in the middle, but there was a little bit of cancer left. Maybe you need to give them something afterwards because that did not do the job completely in the breast. Then maybe it didn't do the job completely outside of the breast either. So chemotherapy, a lot of times before surgery, and then that chemotherapy is combined with some kind of anti-HER2 antibody. And there are two main ones that are commonly used. One is called Herceptin. This is our oldest anti-HER2 antibody, was kind of developed in the 1990s and is still the best one in terms of being combined with chemo. And what it does, it basically binds to the HER2 and prevents it from binding to its partner, and therefore the signaling doesn't happen. And a second anti-HER2 antibody is pertuzumab or Perjeta. That's another medicine that is a lot of times added. And if there's residual disease found at the time of surgery, meaning our goals are so lofty that we actually are hoping that there's absolutely no cancer left when the surgeon actually takes the patient to finally do the operation. But if there is some, then there's a so-called smart chemotherapy that is currently approved for this scenario. It's called Kadcyla, and it's very cool. It's the first chemotherapy, so-called targeted smart chemo that was approved for any cancer. And what it is Herceptin, the antibody, with glued onto it chemo. So basically, the Herceptin takes the chemo to the cancer cells, gets inside, only then is the chemo released from the molecule of Kadcyla, therefore is targeted. That's what we wanted for the longest time, chemo that only attacks cancer cells and not everything that divides. So Kadcyla is that. So people actually keep their hair on this thing, which is amazing. It's still not as good as traditional chemo, which is why we still start with chemo, but it can finish the job if chemo didn't do it completely. And I guess I have a picture of it here too. So that is Herceptin, and these are the little chemo molecules that have been glued on it, for lack of a better word. And then the whole thing gets inside the cancer cells, and then the chemo is released. We call it the payload is released. Is actually medical conferences, that's what we call it. And it can kill the cancer cell. And I'm not talking about a second smart chemotherapy drug. It's called Enhertu. I'm not sure if I have another slide on it or not. If I don't, I'll get back to that. But that's another smart chemotherapy drug. It's not approved in the stage 1 to 3 breast cancer patients, but it is approved in the stage 4 breast cancer patients. Now, a little briefly about triple negative breast cancer. So those are cancers that don't have estrogen receptor, don't have HER2 receptor. So they're kind of put in this basket. Just the only thing they have in common is what they don't have. But there are different types of cancers in this basket. There are some triple negatives that melt away. Any chemo you give them, it just melts away and responds beautifully. There are some that come in the middle, and there's some that are very hardy. Like it's very hard to get chemo to work on them or anything to really work on them. And until you try, you don't know. So because of that, again, we want to give chemo before surgery for these patients, because then you can see, did the chemo that I choose do the job? Did it not? Do I need to do something more or not? Because it's very much a black box. Triple negatives are. Doesn't mean we can't treat them. Doesn't mean we can't cure patients with this cancer if it's found at stage 1 to 3. But we don't know exactly which chemo is going to get the job done. And a lot of times we use immunotherapy for patients with triple negative breast cancer. Immunotherapy is currently approved, and we figured out how to make it work only in triple negative breast cancer, not in other types of breast cancer. But let me explain what we mean when we hear about immunotherapy. So what does that mean? So if you look at the diagram on the left, let's say the T cell is your immune cell, and there's a tumor cell. Tumor cells are not normal cells. So they're going to have proteins on their surface and inside them, but important to us right now for this discussion, proteins on their surface that are not supposed to be there, so-called antigens. So when the immune cell sees these antigens and makes a link, it should say, aha, you shouldn't be here. This is abnormal. I need to get rid of you. But a lot of tumor cells have figured out other ways of getting around the problem of proteins on their surface. And one of that is some of them have this protein called PDL1 on their surface. It stands for Programmed Death Ligand 1. And that has a receptor on the T cells as a partner. When these two connect, this acts as a mask and tells the immune system that ignore everything else you see, ignore every other signal that is coming from me, I am okay. And completely antagonizes the immune system and immune cell does not no longer try to destroy the cancer cell. So now we have drugs that can break apart this connection. So there are drugs that can cover this or drugs that can cover this, antibodies for either one of them. And when either one of these is now covered up, this connection can no longer happen, then the immune system can actually be free to act upon the original signal, the bad signal that the tumor cell is giving off. Now, why just triple negative breast cancer patients cells? Because those triple negative cancer cells are usually more aggressive, more abnormal. They have more of these proteins on the surface, and our immune system seems to only be able to recognize them. But hoping in the future that's also is other types of cancer. So for triple negative breast cancer, therefore, if the patient is able to, we add immunotherapy, which is just basically an IV drug antibody against one of those two proteins that I said. And the main drug that is currently on the market is called Keytruda. And so this is added to chemotherapy. Both can be in the scenario before surgery, as well as people in metastatic breast cancer. Again, they're triple negative. And it really improves whether it's the cure rate or how much what percentage of cancer cells are gone by the time you go for surgery in the localized setting, or remission prolongation in people who have stage 4 breast cancer. So in conclusion, breast cancer can be curable when diagnosed early. Treatment involves surgery and also frequently chemotherapy, hormonal therapy, and radiation therapy. And this is crucial that a lot of people, when they're diagnosed, they just go see a breast surgeon. Breast cancer therapy is very multidisciplinary. You need the whole team. You need the medical oncologist, which is me. You need the surgeon, obviously, but you also need radiation oncologists. And the best scenario is actually if you can meet with everybody on the same day, which we try to do when we see breast cancer patients, so that your treatment can be actually coordinated. And if in this person's particular situation, it makes sense for them to get some kind of treatment before surgery, you don't lose that window. And you're able to get the best treatment for you, whether it's surgery up front, whether it's some kind of treatment beforehand. And we just lighted up hospital pink, so I wanted to show a picture of that. And that is that. I wanted to leave plenty of time for questions. I know it's only half an hour into the talk, but I would love to answer some questions, and we'll see what's in the chat, as well as I know there were some questions that were sent online. Thank you for your attention. So let me see now. I'll start with the chat and kind of go from there. Okay. All right, first question. Why is there so much confusion as to whether DCIS is or is not a cancer? So I didn't really touch base on DCIS, so I'm glad you brought that up. So remember when I said on the pathology report, when someone is diagnosed with breast cancer, it will say invasive ductal or lobular carcinoma. There are some other types too, but the word invasive. So the word invasive means that it broke through the duct or lobule or whatever wall it originated in. So that is opposite of DCIS. DCIS stands for ductal carcinoma in situ. So let's say it's ductal, right? Ductal, so it started in the ducts. Carcinoma is still cancer, but the word in situ means it is contained within the duct wall. So now, whether you think of it as cancer or not depends on your definition of cancer. It is cancer. There are cells that are not normal and they're cancer cells. And when you look at it on a microscope, they look identical to the cancer cells of invasive ductal carcinoma. However, if you think of cancer as something that can spread, something that can kill somebody, this is not that. DCIS is contained, at least at that time. Now, over time, that DCIS may learn to become invasive. It may learn to, get out of the breast. But at that point in time, it hasn't yet. So if you remove it, survival is unchanged. Never have to worry about the rest of the body. So that's why we called it stage 0 cancer, or sometimes it's just easier to say it's precancer. But because it's not cancer in the sense of the word of something that can spread. So hopefully that helps. Let's see. And there was a specific question about DCIS also, like if I have DCIS on one side and fibroadenoma on the other, how much monitor do I need? Fibroadenoma is a benign lesion, so that doesn't need any additional monitoring. And the same thing for DCIS, even though it's, cancer stage 0, and the same thing with invasive ductal carcinoma. Once you've had the surgery, you go back to once a year. You do not need more often types of screening, unless someone has a BRCA mutation and they need MRIs too, or some other scenario like that. But screening goes back to once a year. Thankfully, breast cancer is not this super fast thing that is going to recur so quickly, and you need to get a mammogram more often. Can you speak to the risk of a mass of breast cancer any size? Let me see, where did actually something just disappeared. I don't know where that question went. So let me go to the next question. For what reason are triple negative breast cancers considered the most challenging? Because we don't know what treatment works. We don't have something targeted. Like for HER2, we have the anti-HER2 antibodies. We have something specific for that type of breast cancer. For estrogen-positive breast cancers, we have the anti-estrogen treatment, something specific to them. For triple negative, we don't have anything specific for the most part. So that's number one. Number two, they are also on average more aggressive, more faster growing. So both of those things. Let's see. Okay, that message that disappeared is back. Can you speak to the risk of a mass that is being squeezed, and if the cancer can spread as a result of the mammogram? Question number one, and question number two, differentiate between 2D and 3D mammogram. Breast cancer does spread that way, so you can't squeeze it into spreading. Biopsy doesn't spread it either, because breast cancer is not this thing that has a nice sac around it, is nicely contained, and you can burst or you can make it squeeze, get out. It's already microscopically infiltrated. So if you look at it on a microscope, it's already like this, finger-like projections. So it's already gone to the blood if it has, it's already in the breast. So that's why we get a whole margin around, because we know this is not this nice circular contained thing. There are cancers that are like that, though. For example, testicular cancer, we don't biopsy because it is usually nicely in a sac. And if you biopsy, you can sometimes make it come out of the sac. But breast cancer is not that. So wouldn't worry about mammograms spreading something or biopsy spreading something. 2D versus 3D. So hopefully most of you are getting 3D mammograms. I know at St. John's, it's automatic. Everybody gets 3D mammograms. It's better than a 2D mammogram in terms of seeing things better. They're actually nice layers that that the radiologist can scroll through for smaller cancers or people whose cancer is dense. So ask for it. Where if you're going somewhere and you're not sure, is mine 2D? Mine is 3D. And if it's 2D, usually you can pay a little bit extra, sometimes more than a little, it depends on the place, and get a 3D. If you can at all, I would get a 3D mammogram. How long do you need to take an aromatase inhibitor, especially if you have severe joint pain? Well, the current guidelines is to take an anti-estrogen medicine for 5 years, sometimes longer. Now, is 3 years enough? I don't know. It's not like I know in a specific person when the cancer really went away. Maybe the cancer was not even there at the beginning. I don't know. Did it go away after 1 year? Did it go after 2 years? Did it go after 3 years? I don't know. So that's why we try to get to 5 years, if at all possible, because that's how the trials were done. And that's where the cure rates percentages come from patients who took it for 5 years. So, but you have to balance that with what other side effects someone else has and whether they can be managed or not. And then there are 3 drugs, aromatase inhibitors in the same class. I usually try to change things around and see if another one would work better. But it's a discussion with your oncologist. Taking consideration your cancer's risk, what is your risk in general, how long have you done, and how bad are your symptoms. But there's no absolute in this. Question is, I would like to know how patients can address cancer stem cells. And I've heard chemo and radiation not reduce those. It's we think more about stem cells in terms of stem cells that are in the bone marrow. Breast cancer, it's not like that. It's not like there's just like 1 or 2 cells. If you get those, then you're good. No, so it's impossible to know the one cell that has started it all, and neither is it important to find that. You just need everything that is there out and then treated for cancer cells that could have escaped. It's not like only the stem cell escapes. So once you take the cancer cell out with surgery and you treat someone for the rest of their body, that's the goal. So there's no specific cell that you're trying to find. Let's see. What is the length of treatment with tamoxifen? So same thing with aromatase inhibitors. We're trying to get to 5 years. Just like with aromatase inhibitors, there is some evidence that 10 versus 5 years can be beneficial, but everybody's cancer is different. Everybody's benefit is different. And this person asked, they mentioned their oncotype score. Duration of tamoxifen has nothing to do with the oncotype score. Oncotype can only predict benefit from chemo versus not, and what are the odds of the cancer coming back with 5 years of treatment. It does not answer the question of whether you can do longer or longer benefits or not. There is one test that, the only test that has some evidence at least on answering this question of 5 versus 10, not less than 5, but 5 versus 10 years of tamoxifen or aromatase inhibitor, and it's called Breast Cancer Index. And that test, like Oncotype, is sent from the tumor and focuses on a couple of other genes than Oncotype did, and has some evidence that it can predict who benefits and who doesn't. So if you're at the 5 year or trying to figure out whether to do longer, that's a test potentially that you can send. Oncotype doesn't answer that. All right. Let's see. Fasting before chemo. Can fasting increase the effectiveness of chemo? Is it dry fasting, water fasting, that kind of thing? So seems like there's some evidence that being lighter, I put it in that category first, being lighter and not coming with a, after big meal, helps people have less side effects, have less nausea with chemo. That's more for sure. Now, does it help the effectiveness of cancer? That is not for sure, and it's not set in stone at all. Can it harm things? Because there's some studies that say, maybe in laboratory or mice or what have you, that if you fast, chemo can work better. So should I just try it? I tell my patients, as long as you're not dehydrated and you're not losing weight, it's fine if you want to try it. That's the only thing I worry about. I don't want you to be, like your kidney labs now be out of whack and you're being dehydrated and increase the side effects of chemo. But if you're used to fasting, it's not a big deal to you. It's not like that hard on your body, whether it's water fast or complete fast, you can do it. Now, does it really help chemo work better? I think the jury is out on that. And I wouldn't say that that's the case, the reason you need to do it. But some people have less side effects. So yeah, so I'm for it if a person wants to try it, but it's not something that automatically tell everybody to do because it's not easy for everyone to do this. Is the safety profile of immunotherapy different than of chemo? Yes, it is. Completely different. So immunotherapy doesn't cause hair loss, has nothing to do with that. Usually doesn't cause nausea or vomiting or even fatigue, usually. What it can do is make your immune cells be too active. And when they do that, they can mistake normal cells as cancer cells too, and start attacking your own normal cells and cause so-called autoimmune issues, that's what autoimmune diseases are, is when your immune system is attacking cells it shouldn't be. The most common is the thyroid. So a lot of times, 5 to 10% of people, that's what I mean by a lot of times, can get hypothyroidism. So their thyroid is affected by immunotherapy and they need to be on a thyroid replacement forever because that doesn't wake back up. But that's a pill, it's easy to take, and it's not the majority of people, and is worth curing cancer. So we take that risk. But that's something that can happen. And the more serious things can happen too. Can cause autoimmune in the bowels or in the lung. People can have shortness of breath. People can have bad diarrhea. Can affect even less common things like the adrenal gland, things like that. So usually there's an answer to those things, but extremely rarely someone can even die of this, just like anybody can die of like chemotherapy toxicity. But thankfully it's very, very rare. But yes, it has specific things that one needs to watch for. Let's see, any complementary medicine, anything else that one can do, and then supplements in general. So the problem is a lot of these things just we don't know and they haven't been studied. So because of that, I tell people not to take majority of supplements during the active part of chemo. In case it affects the liver labs while I am trying to get the chemo treatments through the liver and cleaned and all of that. Things that are for sure safe, vitamin D, vitamin C, but you don't need IV, just an oral vitamin C if you want to take it. Sometimes calcium, those things are fine. And then afterwards, turmeric is fine, ginkgo is fine, lime mains is fine. A lot of things are fine, and you can go through them with your oncologist to, discuss that. Do we know? Do we not know? What do they think about that particular thing? But aside from supplements and stuff, I highly also recommend acupuncture, because it falls into a category of alternative and complementary. It can help with chemo-induced fatigue. It can help with joint pain that comes with anti-estrogen treatments. It can help him with hot flashes. So it has a lot of benefits. The negative is that a lot of times it's not insurance covered and it requires commitment, it requires a lengthy thing. So that's the only thing. But otherwise, I would recommend that too. And I'm happy, usually, and most oncologists are happy to work with your complementary medicine doctor to try to figure this out. Okay. Next question. Hormone replacement therapy, my favorite topic, are very common. Many of my friends are taking them. Can these master diagnosis process increase false positive, false negatives, that kind of stuff? Okay, it's a big topic. So hormone replacement therapy, like a lot of topics in medicine, has been on a pendulum swing, and we've gone back and forth on this. So for a while, like 1970s, I would say, or maybe 1980s, everybody, as soon as they had hot flashes, put them on menopause, hormone replacement therapy. That's what it was. That's what you were supposed to do. It was part of the treatment. Then Women's Health Initiative came up with increased risk of breast cancer with hormone replacement therapy. And then the pendulum swung completely the other way. Nobody ever should be on hormone replacement therapy. Nobody, doesn't matter, you're dying of hot flashes, you cannot be on hormone replacement therapy, no matter your age, no matter your circumstances. And now it seems like we're swinging the other way. Like there's been some data on so-called bioidentical hormones, and maybe more research that the risks seem to be not as much as we thought. And now, again, is more and more acceptance of hormone replacement therapy. In general, I would say the risk of hormone replacement therapy as it relates to breast cancer is lowest in younger patients. So patients who are in their 40s and having menopausal symptoms, or in their 50s. Not only is the risk of hormone replacement therapy in terms of causing breast cancer is lower in them, but also the side effects of menopause are more severe in them. So if a woman in that age has symptoms that cannot be controlled otherwise, still your first resort is doing it something that doesn't increase risk of breast cancer at all. So if you can't control the other ways and is affecting quality of life, the risk to the breast is low, and is a discussion with your doctor, and it's okay. But do I want people in their 80s to be on hormone replacement therapy? No. The longer the older someone is and is still on hormone replacement therapy, the risk of breast cancer goes much, much higher. And so anybody who gets started, if they can, the plan should be to try to wean off as they get older. Number one. Number two, in terms of diagnostic imaging, for someone who's on hormone replacement therapy, their breasts are going to be more active and probably more dense. So sometimes they need ultrasound, sometimes they need additional diagnostic imaging, but depends on their person's breast. Not everybody that happens to them. So that's a discussion with your doctor. And once someone is diagnosed with breast cancer, is a completely different ballgame. Because if someone is diagnosed with a hormone-dependent breast cancer, then they really shouldn't be on hormones, because if there are any cancer cells left, you're actively feeding them with hormones, because that is their food. So it's really important in them, if at all possible, to not be on hormones. But it's a big topic, and it's controversial. So you may, hear from, other types of doctors that, oh, it's fine, it's okay. But it's important to know that it's nuanced and depends on that person, their age, their symptoms. Okay, next question. Is there a large percentage of recovery for HER2-positive breast cancer? Is prognosis for better life with all forms of treatment? I'm not sure exactly what the person is asking, but HER2-positive breast cancer has a very high cure rate if treated correctly. So let's say someone has a stage 1 HER2-positive breast cancer, and they're treated correctly with chemotherapy and anti-HER2 therapy. The cure rate could be as high as like 95%. But the treatment can be hard. Chemo with anti-HER2 therapy can be pretty taxing depending on the actual regimen. So it's not easy to get through it, and they need chemo when otherwise for stage 1 of other cancers they may not have, but the cure rate ends up being very high. So hopefully that answers your question. Are all aromatase inhibitors equally effective in invasive lobular cancer? Yes, it doesn't matter. All aromatase inhibitors are the same. None of them have been proven to be better than any other, whether in terms of efficacy or in terms of side effects, on average. But in a given person, drug A may agree with you better than drug B, or so forth. So if whatever you start with is not agreeing with you, you have side effects, do try another drug in the same class. Are there any breast cancers that benefit from being on hormone replacement therapy? I kind of mentioned that already. But I guess I didn't touch base on someone who has a triple negative breast cancer. So triple negative breast cancer, which is not dependent on hormones, then if someone is on hormones, doesn't feed their cancer. So that part is good. But let's say they're 80 and they're still on hormone replacement therapy, they have the risk of other breast cancers happening in the future. So still for them, as they get older, if they can, I would like them not to be on hormone replacement therapy. But let's say in their 50s, they're just diagnosed with triple negative breast cancer and the hormones are helping them with their hot flashes, it's okay to continue. Keytruda. So yes, so Keytruda I didn't talk about. So Keytruda, what that is well, Keytruda I talked about. In HER2 I didn't talk about, but Keytruda in HER2 I want to talk about as well. So in HER2 is an anti-HER2 drug like Kadcyla that is smart chemo, but it's it has a so-called bystander effect. So what does that mean? So when it goes to the HER2 positive cells and the chemo is released, it can diffuse out of the membrane of that cell and attack the cells next to it too. So it's actually less targeted, but that's a good thing because seems like people who even have a little HER2, so they're not HER2 positive in the traditional sense of the word, but they have HER2 low, so-called, so they have a little bit of HER2, Enhertu still works on them. So Enhertu is a drug that can be used in that scenario. And as for this person's question of Keytruda versus with Enhertu, that is not a combination that has been studied. Now, is there a reason why it shouldn't work? Maybe can work. There's no interaction between the two, but it's not a standard protocol or something that has been approved at this time. Oh, and somebody did ask about HER2 low. So HER2 low, if that person is metastatic, then you can use Enhertu as one of your drugs. If they are not metastatic, then HER2 low doesn't matter, and the treatment is the same as HER2 negative. Because Enhertu is the only drug that is approved for HER2 low, and is only approved in a metastatic setting, not in the localized setting. Okay, we have like 6 minutes left, so let me see what other questions I can get through. Let's see. There are several so-called alternative treatment centers that talk about different testings that are not covered by insurance. Why are these tests not standard, and why do they actually offer real advantages? Rule of thumb, be suspicious of treatments that are not approved. Usually there's a reason they're not approved. In the US, we are not very picky in terms of getting things approved. And Europe, they actually take into more consideration costs and things like that. And here in the US, like if something has some efficacy, doesn't matter the cost, it will get approved. So there's a lower threshold in terms of getting things approved. So when things still are not approved in this country, then be suspicious as to whether there is good evidence that they work. So that's what I would say. There's no treatment per se that is not approved that I wished was approved and that I would have given to my patients if they had the money to spare. So yes, thankfully the treatments that we want are approved. The treatments that we have efficacy for are approved, and a lot of these other alternative treatments, unfortunately, don't have enough evidence to back them. They may work in one person, and but they will not work on average. Okay, is the current politics affecting breast cancer research? Unfortunately, it is. A lot of funding has been put on hold and is uncertain, to say the least. And so now clinical trials, thankfully, are ongoing. That's not affected because a lot of clinical trials, for better or for worse, are sponsored by the pharmaceutical companies, and that is not affected. But the pipeline where these drugs are first kind of discovered, a lot of times happens with labs, with basic scientists showing that it basically shows up there like, it has to be developed there. And if you don't pay, have these grants that, a lot of them won't turn out to be any cancer, actual drugs, but some of them would, then our pipeline will dry up. And hopefully that is not the case, but that is a worry right now. With DCIS, would you recommend taking an aromatase inhibitor? So with DCIS, you can take endocrine therapy too, but it's not going to change survival because survival is excellent anyways. But it does reduce the odds of DCIS coming back or a new breast cancer coming. So reduce the odds of you having to deal with this again. So then you have to weigh that against what side effects you could be potentially having. So if someone has, more than a little DCIS, I would say it's worth a try if they are open to the idea of taking medication. But it's not worth hell and high water if like you have horrible side effects. You do not need to do it because most of those patients do not have their cancer come back, and survival is unchanged whether you take this medicine or not. Should you have a CT or a whole body scan when you get diagnosed? Depends on the person's cancer and depends on the stage. Let's say we already see that a lymph node is positive, then yeah, a lot of times we do scan the rest of the body to make sure we're not missing anything. But not everybody needs a scan, and the type of scan depends on kind of the type of breast cancer. So like if it's a slow growing cancer, I wouldn't do a PET. If it's a aggressive cancer, I would do a PET. So it kind of depends. But yes, some kind of scanning if there's at least lymph node involvement or a very aggressive cancer, or you have reason for thinking about cause. And I think I'll answer two last questions. One is, does Ki67 dictate treatment? Kind of. Ki67 is a protein that gets expressed when the cells are dividing. So we use it as a rough measure of how aggressive a cancer is. So it may make me want to or not want to send oncotype, but it shouldn't be the sole thing that you base treatment on. Oncotype is a much better test. And Ki67 is actually one of the 16 genes that can oncotype test. But it's much more nuanced, much more exact. So it shouldn't be the only thing. MRI, and then the last question, MRI with or without contrast for dense breast. First of all, you definitely need contrast with MRI. Without contrast, it's not helpful at all. So don't go through the whole thing and not get contrast. You either do with the contrast or not at all. And does everybody need it who has dense breast? No, because MRI can also have a lot of false positives. So a lot of things can light up, and then you have to, now biopsy this, biopsy that, and leads to unnecessary medical testing. So most people do not need MRIs. But I mentioned at the beginning, there are some scenarios that do, like lobular cancer, young people, and have a discussion with your doctor. Depends on your scenario and your exact whether you have a gene or what the cancer is that you're dealing with. But most people do not need MRIs. And somebody asked if this is recorded. Yes, it is. And you can watch it later, but Kathy will tell us where and how to find it. And I am done.
Oh, thank you so much. This presentation was so meaningful. And if you get a chance to look at the chat, Dr. Peddi, you'll see how meaningful.
I did. Thank you so much, everybody who said thank you. I enjoyed doing this too.
Yeah. So thank you for all the information and for just so candidly answering all of those questions. We really appreciate your time today. And then we have a closing slide that Abby's going to share. And I want to thank all of our participants too. What wonderful engagement today with Dr. Peddi. So thank you so much for joining us and for your thoughtful and meaningful questions. And then if you want to learn more about Cancer Support Community Los Angeles, you can visit our website, cancersupportla.org. And if you have any questions for us, please email at info@cancersupportla.org. We are happy to answer your questions. We do have a breast cancer support group. So if you're in need of that kind of support, this is just one example of the many programs that we offer to get started. You can scan this QR code, or you can go to our website or email us. So thank you everyone for joining us. It's time to say goodbye. We really appreciate you. Thank you again, Dr. Petty, and have a great rest of your day. And we will see everyone again at a future webinar. Thank you.